welcome everyone. Again, my name is Helena, and it's really a privilege and really fun to work with. It's been awesome actually working with Kurt and Bob on this project. I feel like I need to amend the disclosure a little bit. I don't have expertise in this topic, but one of the things that I emphasized when I was presenting earlier is that I really do think it'll be just an awesome experience to learn from each other. So it's very interesting that as one of the consequences of the COVID epidemic was there was essentially a massive resignation that occurred in around 2021. And what was the most common reason for this massive attrition from employees? They were citing a toxic work culture. And as a result, companies were driven to identify, well, what actually constitutes a toxic work culture, because you can't really solve a problem if you can't identify what the problem is. So they really want to pinpoint it down to like highly specific elements. And as a consequence, MIT Sloan Management Review published this very interesting article that's included as a resource in the back of that paper. And they cited the top 5 reasons or attributes of a toxic work environment. And before I go through the list with you, one of the comments I'll make, which is pretty fascinating, is that in lieu of even compensation, a toxic work environment was 10 times more likely for employees to leave their company. They would suffer a smaller compensation and deal with that tenfold more than dealing with a toxic work culture. So you can see that basically the list is the following: cutthroat, unethical, abusive, non-inclusive, and disrespectful. These are the 5 attributes that the 120 million people who were surveyed from those Culture 500 companies representing 40 completely distinct industries consistently reported as being constituting a toxic work environment. And another interesting fact is that it was actually disrespectful that was the most common one. People could tolerate some of the other more toxicities, but to be disrespected was sort of the ultimate. So I'd like to hand it off to Bob. He's going to elaborate a little bit on what actually the impact on the different levels in a medical setting are as a consequence of these attributes being present in a work environment.
So I think this has already been alluded to in the opening session, and we're all aware of it. I do want to repeat some of the costs associated with toxicity. Helena just mentioned the exit of employees, so turnover is a huge problem. Morale is a related issue, so even those who don't leave, who stay, are demoralized. Trust among colleagues is eroded. And with that, in the patient care setting comes the fact that people are maybe a little less reluctant to speak up when they see something that they don't agree with, or in the case of the operating room, speaking up when they see a problem. They stop listening to one another, and with that they don't learn from one another, people don't share their mistakes. And that all equates into very real issues that were alluded to. The cost of care goes up, the number of quality and safety events is associated with the increased toxicity, malpractice rates go up, physician burnout goes up. We're, I think, all familiar with these. So the costs, if they're not already evident to you, if you haven't seen it, they're pervasive in all of healthcare, not just in the business world that Helena referenced. So I think that's the compelling reason why all of us are concerned about this issue. And hopefully the case discussions we get to have here will highlight some of those issues and how to deal. That's the most important thing, is how to deal with it. Some tips or tools that we could potentially de-escalate these events when they occur. So Kurt, I think, has
when we started this, we recognized there's no evidence base for how to address a toxic work environment. And so we assume that this is the first installment in a journey that our professional community will go on as we learn together about how to address this. So the first, my job is to give you 3 principles. And these 3 principles I will invite you to use in these scenarios as we form you into groups of 3 and you discuss the scenarios that are on your tab. So the North Star is a question that you ask yourself when you're in a difficult environment what do I really want? What motivates me? What am I interested in getting out of this situation? Because it influences how you behave. If you really want to get even with the person that's toxic in your environment, or you want to get even with the CFO that's driving your group with RVUs, then that's a, but asking the question and being clear about what you want is super important. The reason we're using these slides is because these are concepts that are maybe easily seen than spoken about. Your circle of concern. I'm really worried about poaching ivory in Africa. I can't do a thing about that. And the more time I spend on something that I have no influence over means I'm less effective in the other parts of my life. The circle of influence, on the other hand, is where you spend your time, where people listen to you and are eager to hear what you have to say, where you can do something in an environment, a work environment or a family environment or an institutional environment where you can influence the outcome of things. Your circle of control is your choices. Do I speak up or not? Do I exercise or not? Do I get out of bed or not? These are things that are entirely in your control. If you spend more time focused on your circle of influence, your trust in your organization, your influence in your organization grows. The more time you spend in the circle of concern, the more time you are wasting and the less effective you become at the things that you can really influence. The last principle is, what's your story? When you're involved in a difficult situation with people or an institution, you want to ask yourself the question first, what's my contribution? How am I influencing this? Is there a pool of data that describes our situation? This is how I feel about this. The institution responds. You try to find a pool of common understanding and begin testing results to see if you can move from that place. So what we'd like to do now is have you be in groups of 3. So Sharif, if you would come around and sit in this chair, and Joan, if you would come around and sit in this chair, and then Amanda, if you would, Amanda, you're right here, okay, and then David, I hate wake you up, and you come around and sit in this chair. Okay, now, we've given you, Helena, have we decided, since we have a small group, are we going to give them a choice to choose, or what are we going to do? Okay, so here's the deal. You have 3 scenarios. As a group, you should pick one. Why don't you pick the first scenario, since you're group 1? Why don't you do the second scenario as group 2? And why don't you do the third scenario? Okay? And so these are the questions. We want you to apply those 3 principles. What's your story, or what's your North Star, and what's your circle of influence and concern? And answer these 3 questions. And when you come back in 10 minutes, we're going to ask you to answer these questions. What did you notice or learn? What did you feel about this? And what will you do tomorrow when you get home? Ready, set, go.
Sure. So let's start with group 1. As Helena was just saying in this group, this is probably the most difficult scenario, and it's a little different from the other 2. But to summarize it, for those of you who haven't read it, you're in a faculty meeting, and the hospital leadership has basically created an edict that your compensation is now at risk unless your productivity goes up. So which of you 3 is going to summarize your discussion and try to focus on the answer to these 3 questions here? What did you learn? What did you notice?
So what we learned and noticed is that the hospital president has a problem, and they've come up with a solution in a very autocratic way with no involvement of others, even seemingly the surgeon in chief or the division chiefs. And that's put the surgeon-in-chief in a bad position with those below him, and everyone else is outraged because it's a significant amount of at risk now, and that this new edict actually sort of creates a toxic environment. It is a toxic environment for the surgeon-in-chief, but it creates it for, or has the potential to create it for everyone else. And we felt that with a more democratic process or a more inclusive process and discussion of creative solutions and collaborative multidisciplinary solutions to the problem, acknowledging that the problem exists, that the hospital president is approaching a problem, but then trying to be more collaborative in creative solutions to the problem would help involve everyone and at least hear their concerns and hear their thoughts on what are at the roots of the problems. And what will you do when you get home Monday? Meaning, what will I do at home from this? I think the key here is that.
Sorry to interrupt, but
Yep.
spend a moment talking about how, in the moment, how you could react to make this a more constructive conversation.
Sure. So in the moment, in the question, we're the surgeon-in-chief, and the president has just said this to all the division chiefs. So I think in the moment, acknowledging the problem, acknowledging the fact that, yes, productivity has been down, but then raising the concern that perhaps just telling the surgeons to work harder might not actually fix the problem, and that we need a better way to understand what the actual problems that led to, what the actual roots are for this problem. So is productivity down because there's a new competitor in the market and they're taking all your patients and that's an issue? Or is it down because you don't have enough nurses to staff your ORs and so you can't keep as many ORs running? Or do you not have people in central sterile supply like us and can't get your trays sterilized to do cases? It's just a local problem. Or not a local. Or is it really a surgeon issue? But then be able to come up with creative solutions with all of the involved players so that it's not putting the burden on one group, so to speak.
Thank you. And I just wanted to underline one of the things you said. On the back is a reference called Crucial Conversations. Those of you who have not read it, when you're in a difficult conversation, acknowledging the other person's perspective is an essential beginning, and avoiding the use of the word but, saying, yes, the hospital finances are troublesome, and we want to be part of the solution. We would really like to be part of that solution and not just be told.
In particular, a difficult conversation for the states are really and that's, I think the others are as well, but in particular here.
What's that?
Sorry, I apologize. I think what you're pointing out was amazing. Thank you. But in particular, this is a difficult conversation where the stakes are really high. They're talking about a significant piece of your salary, and obviously that financial situation like that could impact people and be pretty devastating. But the Crucial Conversations was something that we were talking about a lot during this discussion and very helpful.
So the second scenario is you witness your partner losing his or her cool in the operating room and is abusive to the resident. So which one of you is going to let us know what your discussion was all about?
Okay.
Okay, we'll try to get to the point on this case. So we were given the case of a partner who's working with a resident, and it sounds like it's been a long day, a difficult case. The partner's getting frustrated, and we're walking into this. And how can we be effective and try to improve this environment? So we came up immediately with several principles when we're approaching this case. One of the first one we thought of course, is everything has to be about the patient. So we want to make sure that the situation, everyone is behaving in a way that's competent and bring professionalism to the situation. And then the next thing we thought of is, well, walking into someone else's OR can sometimes also be interpreted as crossing their boundary, and so we wanted to bring a principle, actually, which Abigail mentioned, which was making ear statements. So EAR stands for empathy, attention, and respect. So first just asking permission, like, and we don't know a lot about this scenario, but we thought first just asking permission, and being humble, saying, you know, just would it be okay if I come into your OR? No, you guys have had a long day, just walking by, and there's a lot of unknowns with this scenario. We don't know, is this a senior partner, a junior partner? Do you have a good relationship with this person usually, or do you have a good chief? We don't. There's a lot of unknowns with this scenario. But first, just trying to immediately establish trust and rapport, permission, respect when you walk into the OR with a different surgeon who's in charge of the patient. And then making an empathetic statement, like, because you want to partner with these people, saying, this looks like a really difficult case, or would it be okay if I take a look? We know it's an interesting case. So just something to try to get some communication going and try to partner with them so that you can actually do something effective. The A stands for, Abigail, attention. So that kind of goes with what I have said, and then just being respectful. And I mean, in this type of scenario, you need to, it really, I think, revolves around communication and how you set the environment. So you want to bring the level of the discussion down, get things focused back on the case. How are we going to make sure this case is completed safely, and bring the attention back to that. So we're talking about the EAR, EAR principles that we could use to make sure that this case is completed safely and that competence and professionalism are brought into the whole scenario.
Thank you. That's great. If we had a little bit more time, the other thing we'd want to touch on is the impact on the resident and what you could do to, yeah. Dr. Powell, is you?
Okay, so we had a scenario wherein we had a baby with a distended belly, a cardiac baby, and the CT surgeon wants us to operate on an acute abdomen, and says a competent surgeon would have already operated. We also started similarly with empathy. You know, I understand we are both concerned about this baby. So empathy, acknowledging that we're both on the same page and our common goal is to take good care of this patient, and staying calm, and then also Dr. Powell talked about citing evidence of, you know, in babies with a single ventricle, with, you know, the likelihood of it actually being a, you know, something other than simply ischemic bowel is pretty low, or so, yeah. Right. So, right, exactly. So, citing data, and then you know, and also potentially doing a physical exam, feeling belly while doing this, and then also potentially suggesting taking the conversation offline, so that it's not in a group of a lot of people and putting people in an awkward situation. Yeah.
There's one more thing here that we didn't talk about. One more principle. Sorry, I knew this would make David happy. There will come a time, occasionally, when you will have done your best, using the best principles you can, And if the environment is unethical, if it's dangerous to you or to your family or to your marriage at home, there are things that you'll find as you investigate this that will help you understand in your unique situation if it's time to go. And we can't counsel you on that. That's a 3-hour discussion on another day. But so we invite you to consider these things. And I would say in the feedback about the session, we are learning with you, okay? And so if there is something that we did that was really unhelpful, please tell us, okay? Because the people who do this next time will want to know that. And we want to, bis nächste Jahr, thank you, danke. See you guys, okay? I assume that you just did on your phone. So you guys remember, if you go to the session, the 9:45, 10:15 session, click on Show More, and when you do that, it will show, it will tell you a description. At the top, it says Activate the session, and then you just click the thing that says You are not a robot, and hit Accept, and then it will give you the CME credit, and it will go to your email and invite you to give us feedback, okay? Thank you for coming. Come again.